I am here to welcome a gentleman who I believe practices with my nephrologist, and the topic is taking care of my remaining kidney. Dr. Ramesh, did I get that right? Soundararajan. No, give me your last name.
It's Soundararajan.
Okay, so thank you, Dr. Ramesh. We're really happy to see you today. I have to tell you, before the brain fog and the cancer, I would not be able to pronounce your last name, and I find that offensive of me. So welcome to you. So Dr. Ramesh is going to be coming here, but like many of you, it was very hard getting rid of my twin kidney, and I'm now dealing with one. But like you, I'm doing it. And fortunately, my creatinine and my EGFR are getting back to normal numbers. They're still high, but they're normal for me. We are very fortunate to have Dr. Ramesh speak on us on how to love that remaining kidney of yours and give it the care it needs. A little bit about the doctor. He has been with Associates in Nephrology, which is my doctor's, for over 20 years and has practiced nephrology for 35 years, specializing in hypertension and nephrology, as well as interventional nephrology. The doctor speaks and teaches. Do you see how I'm avoiding your name? The doctor speaks and teaches at national conferences. He's trained at Loyola University and practices in the southern suburbs. So with that, doctor, I appreciate you being here today.
Thank you.
And I'm sorry, I want to hear your name one more time so I can get it right. I'm not leaving it.
It's Soundararajan, but a lot of people call me Dr. Sound. I also tell them it sounds like the sound you hear in your ears.
Okay.
But the J in India is pronounced J, not Ha.
Okay.
Like in
What about,
Mexico.
how about Dr. Ramesh? Isn't that nice?
That's perfectly good.
Dr. Ramesh, everybody.
Okay. Thank you all and for the kind introduction. And it's a hard act to follow. I think you're an excellent speaker. I just talk medical stuff. I don't have all that stand-up comedy kind of stuff with me, but I'll try my little bit. Yeah. But yeah, I mean, I'm a nephrologist, been a nephrologist. I love nephrology. I think it's an awesome specialty. I usually tell my residents and students, nephrology is internal medicine on steroids. So basically, we take care of the patient as a whole, not just the kidney itself. So anyway, having said that, basically, I was tasked with basically saying, hey, you got one kidney left. How do I take care of it well and do the best I can with that? And luckily, there are a lot of things we can do. So I'm just going to go ahead. So let's start with the first thing. So why preservation matters? Each kidney filters about 180 liters of blood every day, and losing one, it puts a long-term burden on the other one. I usually give this example for my patients. Say you have a factory with 100 people working, and now you've fired 50 of them, right? So the rest of the guys are going to say, oh my God, I got to produce the same as 100 people. They're going to either die, get tired, or quit. So you tell them, hey, don't worry. We take care of yourself. Do it slowly. You don't have to produce the whole amount. Do the best you can. And that is partly our philosophy. And there is lifestyle changes, diet, and medications now to help keep that other kidney working and be happy. And that's the key. So, but there is a certain amount of compensation. And like I said, the goal here is to prevent chronic kidney disease and maintain quality of life. So hyperfiltration, which is what basically is, my wife, when I showed her this slide, she says, that's a technical word, so make it simple. So we all filter. So we have what is called a GFR, or glomerular filtration rate, of about 100 mLs per minute. But when you make this one kidney do the job, so it's going to try to do more to compensate for it, and that causes a lot of burden on the filtering unit, and it actually causes fibrosis and what we call a sclerosis or scar tissue. So our idea is to decrease the pressure within that filter, so you don't filter as much, you slow it down, but that way it lasts longer. We are trying to make a kidney going from a sprinter to a marathon runner so it lasts longer. I mean, that's really what we are trying to do here. The things which make that hyperfiltration or high filtration rate are high blood pressure, which means there's more pressure on that filter to push it down, diabetes, excessive weight, which also makes the kidney say, hey, I've got to take care of, process more tissue, and high protein diets. So there are medications you give for cancer which also hurt the kidney function. So that's another thing we have to work with the cancer doctors together. Chemotherapy, immunotherapy, etc. So, like I said, after you take the one kidney out, the numbers may get worse for a short period, but about 70 to 80% of the other kidney does compensate some. I mean, the idea is not to overcompensate. And most donors remain healthy, but you have to keep an eye on them. So most people who have a single kidney, make sure you see your internist for sure, and make sure you see a nephrologist if there's concern. And this talk, I'm actually throwing in people who donate a kidney too. Okay, if they have donated a kidney and they have one kidney and donate for any other reason. So maybe your family member had a kidney cancer, they lost a kidney, you donated a kidney if anybody else. That also is a relevant topic here. So the concept is the same. You have a single functioning kidney, take care of that, right? So important thing is to maintain a healthy weight, exercise regularly. You talked about the salt. So, I mean, definitely more salt, more burden on the kidney to get rid of that salt. And hydration is important. Drink a lot, but again, sometimes you can overdo it also because of the range of diluting and concentrating capacity of a diseased kidney is not as good as a healthy kidney. So we got to keep an eye, but blood work will tell us where we are. And again, this is important. I know there's a lot of, it's mostly in the younger people who just say, no, they have to become like Arnold Schwarzenegger and take a whole bunch of protein. Protein is, to a reasonable extent, is okay, but high protein diet does put a strain on the kidney. So that is important to know. So people with one single kidney do need to. And there are tests you can do. Your primary doctor can do certain tests to look for the strain in the kidney, and I'll explain that in a minute. Okay, big thing, don't smoke. I mean, smoking might have been the cause of the first kidney to have gone bad, but don't want to cause, because smoking is going to damage. Everybody talks about smoking and heart disease, smoking and strokes, but smoking and kidney disease is equally good because kidney is full of blood vessels. 1/5 of the blood supply to the whole body goes to the kidney. So it's very important. And if that gets diseased, your kidney is not going to work so well. And then ibuprofen and Motrin is easily available over the counter, so people don't even think it's a medicine. It is a medicine. It is toxic to the kidney. I'm not saying suffer with pain, but at the same time, talk to your doctors whether it is the right medicine for you. There's a lot of local therapy. In the US, we have this tendency that any pain has to be treated immediately. And a lot of it has to do with our mind and all that stuff. But again, I mean, if this is pain related to cancer, that's a different story. But if it's pain related to because you sprained a muscle or something like that, put some Bengay on, put a heating pad, cooling pad, whatever it is, rather than throw a bunch of Motrin on you. Okay, I mean, that's kind of important. So talk to your doctors, please. Hopefully everybody who has a single functioning kidney has an internist for sure, and maybe a nephrologist. Okay, so blood pressure management. Because you have only one kidney, chances are your blood pressures are going to be a little high. Not everybody. You can have a perfectly normal blood pressure, but if you do, it's a good idea. And I'm a hypertension specialist too, and I strongly believe people should take care of their own blood pressures. Everybody should get a good monitor at home and learn how to monitor their blood pressures. Even if you don't have blood pressure now, because you have a single functioning kidney, you could notice as you age, you might notice that your pressure starts going up. And if it is, but home blood pressures are way more important than that one random blood pressure you take in the doctor's office. I mean, I tell all my patients who come to see me, every one of them, I say, where is your homework? If they don't give their homework, they get a detention. No, I mean, but I do ask them, and most of them do bring me the papers and show me what they've got at home. Because it's just like a blood sugar. You can't get one random sugar in the doctor's office and say, okay, I'm going to increase your insulin, right? You never do. Nobody does that. Same way, blood pressures. You can't take this one. I mean, you must have, your football team might have lost a game the previous evening, and your nurse is talking to you about the football game, or you're late, or the doctor's late, or you couldn't find parking, and all the blood pressure issues. You have a 20 to 30 point increase in blood pressure in the doctor's office compared to home, and I don't want to be treating that and over-treating you or under-treating you. So just per se. So A little technical there. The main medication we use for people with high blood pressure in patients with kidney disease is what they call as a RAS blocker, an ACE or ARB, and that is one of the reasons is it actually slightly decreases the function of the kidney. But like I told you, we're trying to make it a marathon runner. So we're trying to actually slow down the kidney function. You do lose some what we call as GFR or kidney function when you decrease. But in the long run, we found that the slope of decrease of the creatinine of the kidney function is much more gradual when you're on that medication than when you take something else like a calcium channel blocker or anything else. So that's one of the medicines we use more commonly. But again, your doctor, your internist, or your nephrologist would make that call. And the other important thing is watch for any even hidden diabetes. The thing is, not all kidney disease from sugar is related to actual frank diabetes. Nowadays they say A1C of 6.5 or more. 7 is what our goal is, to actually keep it below when we treat somebody. But there's a lot of people with what we call as metabolic syndrome, impaired glucose tolerance, who are not truly diabetic, but who do have kidney disease. I have a whole bunch of people in my practice who are like that. So there are other things we don't understand. Maybe there's a lot of insulin being produced, which is causing some damage too. And so just because your A1C is good, don't assume you should be eating all the sweets in the world, okay? Because A1C is an average. I mean, you can have a sugar of 300 and then 60, and then the average is within normal limits or average. So it's important to talk to your doctor and be aware of that. Diet is very important. I do have another slide on the diet. These DASH and Mediterranean diets are typically talked about for high blood pressure generally, and it's also a healthy diet, but I do have a little bit more on the diet. My next slide is, nutrition. Okay, nutrition, I'm a big proponent, and my wife is a dietitian actually, and she has taught me a lot about diet because she and I talk all the time about that, and then I'm able to transmit that information. So I'm a big proponent of all kidney patients. If you have any degree of kidney, ask your doctor to send you to a dietitian, because they can help you a lot, because this is one of the few fields where a dietitian makes a huge difference in your day-to-day care. Okay, there's a lot of data in the kidney literature about going on a plant-based diet. A plant-based diet, and one of the acronyms is PLADO diet, which means plant-dominant diet, and it depends on the degree of kidney disease you have. If you have fairly moderate to advanced disease, then definitely it will slow down the progression of kidney disease. I don't want to get into the details of the mechanisms of why this happens, but it definitely cuts the workload on the kidney. A simple thing I tell my patients is, if you eat a lot of animal protein, it's going to make your kidney work twice as hard, which just means it's going to burn out twice as fast. Simple thing, okay? But it's very hard for people who've been a meat eater all their lives to suddenly switch over to a plant-based diet. But you can do it gradually. Cut down the portions of animal thing, try to maybe do a couple of meals a day or a week without any animal products on the table, and then slowly you will notice a change. And it definitely cuts down the workload on the kidney. So it's a very simple, low-hanging fruit. And the other one, like I said, I put down there, it decreases the acid load. If you eat a lot of plant-based foods, your end product is alkali. If you eat a lot of animal-based foods, your end product is acid. And eventually, to get rid of the acid, our kidney has to work harder and put a lot more effort. So, I mean, our goal is to slow down the workload of the kidney and let it work. So that is where it is. And unfortunately, today's meat products are all processed and preserved, and all those preservatives and processes make a lot of, and it adds salt to the whole story too, so, and all that stuff. Then fruits, vegetables, whole grains, legumes, nuts are good sources of protein. Now, we have this myth that only animal products give you protein, so it's really not true. There is a lot of data that you can get good protein from vegetable products. I mean, there was an extremely good Netflix documentary from many years ago. You mentioned Netflix, so I thought I'll bring this up. It's called Game Changers, and there's this Olympic weight lifter who could not push past 350, kilos or pounds, whatever he is supposed to lift, and he couldn't get past that. And then he went on a plant-based diet, and apparently he could lift another 50, pounds of kilos, I'm not sure, but whatever so it is possible. And I can tell you my dialysis patients, there are 2 of them who are vegan and their albumin is better than all the other guys who are eating meat. So interesting. So it doesn't have to be. And like I said, limit the red and processed meat. I have a joke for my patients. I tell them, I usually tell them, okay, you got to go on a plant-based diet. He says, okay, I only eat chicken and fish. I said, the last time I checked, chicken and fish don't grow on trees. Okay, and then they'll say, oh, okay, so I should. Then they'll say, okay, I don't eat red meat at all. And then I said, you know what? The heart is actually a racist because it differentiates between white and red. But the kidney is colorblind. It doesn't care what color of meat you eat. So those are the 2 things I say, and it really actually hits the patients well, okay? I did get a laugh out of you guys, okay? Okay, so plant proteins generate less uremic toxin compared to animal proteins. And again, the preservatives are full of phosphorus and that and thing. And when you eat more phosphorus, which is preservatives, your kidney has to work harder to get rid of the phosphorus. And it actually affects your bones too. And that's a whole different area of parathyroid hormone and all that I won't get into. But again, big thing, home cooked meals, because we all tend to order on Uber Dash and Uber Eats and restaurants and stuff like that, because those are all full of salt and processed foods. So you need to try to make fresh foods at home and eat it, wholesome foods, and definitely will help. Okay, so that's the thing. Then the labs, what do you get? I mean, the big thing now is a big thing, which is we talk about the serum creatinine. Now, serum creatinine is unfortunately it's a very, what we call as a specific tool. If it is high, it's bad. But a lot of people have mild to moderate kidney dysfunction, and it's still within the normal range of creatinine. So you cannot pick it up. Unfortunately, right now, the labs only report GFR greater than 60. Now, what about 60 to 90? If normal is 100, 60 to 100, it's just saying greater than 60 and not even reporting it. So that's a big flaw in our system of reporting right now. So there is a new test available, a kid in the block called cystatin C. So I would suggest you ask your doctors, hey, can we check a cystatin C and see if that is off? And if that is off, that means you are, even if you are on stage 2, or even sometimes there's a big discrepancy between cystatin C and creatinine, because creatinine is based on muscle mass, cystatin C is not. Sometimes the difference of the 2, you can actually pick up earlier kidney disease with that cystatin C. So that's a thing, you can take it down, right, to ask your doctor, hey, can you check my cystatin C? The other important thing is, they all check a urine analysis and say it looks clean. But there's another test we in the kidney community are talking about. It's called albumin to creatinine ratio. And I just gave a talk to my residents and fellows a couple of days ago. That's even the primary doctors and internists are not picking up on that. And I'm trying to tell them, if you have hypertension, any other kidney disease, diabetes, or any other thing, check a cystatin C and a urine albumin creatinine ratio. The reason is, if you have an albumin creatinine ratio which is high, there are medicines which you can give to protect you. But also, those are the people you got to tell them to ease up on your animal protein in the diet. So maybe those people the kidney is working harder and do it. But obviously, maintain your blood pressure, lipid profile, and your weight. Ultrasound if there's any suspicion of obstruction, which is something, you have only one kidney. Sometimes you have a kidney stone in that one kidney, and it may not be big enough to block it, but it may be causing some obstruction. Or if you're a male, prostate is always there. I have patients say, oh, no problems, doc. I pee all the time. I have no problems. I get up 8 times at night to go to pee. I'm fine. I've actually put a bladder scan on their bladder. They got like 800 cc sitting out there. They got like a little baby sitting out there. So sometimes even 2,000 I've seen. And they don't even complain. So to get to 2,000 cc's of your bladder, normally with 300 if you want to go to the bathroom, right? 3,000, it took a long time. It slowly got bigger. And the prostate is so big, it's completely blocking it. And they don't know. Sometimes they can't, because the capacity, they only empty a little bit and then they have to fill up again. So, and that backs up into that one kidney you have, and you can get, even if it doesn't look anatomically, there's a pressure causes those things. So it's kind of important to keep an eye on those things. And then look at all the medications. And the other one biggie here, which I have to mention, is everybody takes Nexium or omeprazole for heartburn. It's like common. It's out there. 50-60% of my patients who come to my office are on. I ask them, why are you taking it? I don't know, maybe some heartburn if I eat jalapenos. Okay, don't eat the jalapenos. Because PPIs, or they call proton pump inhibitors, is associated with chronic kidney disease. Okay, we don't have a causality at this point yet, but we have an association. The longer and the higher the dose you take it. And because it's over the counter, everybody thinks, I can eat some some chili chicken or whatever it is, and then go eat a omeprazole, and then I'll be fine, and then keep taking it all the time. So that, look at every medicine. I'm looking at low-hanging fruit. PPAs is a big thing which nobody even talks about. I take a lot of people off it in the office. Then, like I said, microalbumin, I mentioned that. Cystatin C is another big thing which I think it's something you should ask your doctors to check. Hypertension, diabetes, dyslipidemia. Avoid, okay, you go to the hospital, ER, and they say, oh, your creatinine looks normal. Can I just go ahead and give you some contrast? Okay, that's the other thing. Ask them, do I need the contrast? If it is needed, yes. But the contrast itself in certain people can cause, especially if you have dehydration, for example, or if you're on an ACE inhibitor and you're looking dehydrated, then you give you contrast, and the creatinine may still be within the normal range. The ER doctor is going to go ahead and give it to you. But then that's a concern. Sometimes that can cause kidney disease. So just be aware of it. I'm not saying you can question your doctors, hey, no, I don't want contrast. But what I'm saying is okay, but I'm just saying within reason, right? If you have a lot of times they go with, I can't breathe. Oh, I think you may have a clot in your lung. I'm going to give you contrast. That's a different reason. Oh, maybe you got back pain. Let me see what else can I do. Can I do a contrast? No, maybe an ultrasound of the kidney can tell you if there's a stone, or if you can do a plain CT without contrast, you can pick up stones.
Let me violate a rule.
Sure.
Just a question, Judy, just because you brought it up. I have been told from some radiologists that looking at a CT without contrast is like somebody needing glasses and not being able to read a book because they don't have glasses. To handle your issue, and I have low creatinine and EGFR is not where it needs to be. I always get IV infused before and after, and my creatinine has never been affected. And I'm just interested in your opinion that what I've heard lately is radiologists think that this view of no contrast is a little bit overdone, and that the benefits of contrast outweigh the risk. And I just...
Again, like I said, in every situation, just think twice before you order the contrast.
So ask the questions.
Ask the question, it doesn't mean you can't have it. And yes, the contrast from 20 years ago was much more toxic than the contrast today. The osmotic agent of the contrast 20 years ago was 1600 milliosmoles, and now it is closer to 300, which is similar to blood. So it is much less toxic than before. Our incidence of contrast nephropathy is way lower now. But having said that, I have a patient in the hospital who just under our eyes, without my knowledge, got contrast and got kidney disease, had to be on dialysis for 4 days. I have another guy who got contrast who had perfectly normal creatinine, but he has some other disease which they didn't pick up called myeloma. And he got contrast, and he was on dialysis for 2 months, and he's off it, but his kidneys never got back to normal. Having said that, I'm not saying, just ask, hey, is this really needed? Like I said, kidney stone, you can see with a plain X-ray. You don't need contrast. If you're looking for a tumor, and see whether it's gone to spread to different parts of the body, you want to know the blood supply to that tumor, you need the contrast.
Or ask for an MRI.
Okay, MRI, again tricky. MRI with gadolinium is not toxic to the kidney by itself, but if you have bad kidney disease, it doesn't get out of your body. So again, question before you have to do it. It's not like, you were talking about being advocates for yourself, and that's what I'm trying to say. Just question. It doesn't mean you shouldn't have it done. The other important thing is, if you have metabolic acidosis, like if your CO2 on the blood works is 18, 20 or something like that, that means your kidney is not getting rid of the acid like it's supposed to. One of the low-hanging fruits, again, don't do it yourself. Talk to your doctor. If it's 18, 20, then maybe I should take some bicarbonate, and the cheapest way to do it is baking soda. I actually have a lot of my patients take a half a teaspoon of almond baking soda, but only if they have metabolic acidosis. I'm not saying everybody go and take it, okay? I had my patient's family member, I was talking to this patient, say, I want you to do it. Oh, that's good for the kidneys. Can I have some too? No, not everybody. Because I had a patient who had a bicarb baking soda, and she came in always with the bicarb of 45, and I couldn't figure out for 3 admissions. And then she said, oh, I love baking soda. I just scoop it and eat it. So you got to be careful, okay? And then, okay, let's get to this. Okay, newer therapies we have now, one of those is called SGLT2s, which are the Farxiga and the Jardians you see on the TV all the time. But again, under the guidance of a doctor, that may be, if they have protein in the urine, we tend to give it to them based on their GFR. And even if they don't have protein in the urine, if the GFR is below, say, 45, there's data that you can just give it to them. Finerenone is another one. The incidence of heart disease in kidney patients is very, very high. If they get to what we call a CKD3, which can happen when you have one kidney and with aging, because aging itself makes you lose kidney function simply by that, then the incidence of heart disease, heart failure, is higher when you have higher degree of renal insufficiency. And it is asymptomatic in a lot of people, but if you do an echo, you will see what is called diastolic dysfunction. So we tend to be more proactive and put them on SGLT2 if their GFR is below 60. In the right condition. Again, you have to talk to your doctor because there are other side effects of that too, but it's important to think about. Again, finerenone is another one which also helps the heart. It is a mineralocorticoid antagonist. Again, it makes your potassium go high, so you have to be careful about what you're doing. So, but anyway, these are all tools we have in our pocket. We can help keep your kidneys working longer. And then lifestyle, of course, we talked about. And then there's a lot of new because what happens is a lot of scar tissue in the kidney. Unfortunately, we don't know how to reverse the scar tissue at this point. But there are new treatments coming up, which we are waiting to see what they are going on. And like I said, most individuals with one kidney live a full, healthy life. Early intervention and steady monitoring is more effective than proactive than reactive. And then, like I said, partnership physicians and success. And my wife also made sure I wanted to remind you guys to say this is just a general medical advice. Please ask your doctor if you need more specifics, because this is, I mean, each one is, you have to be very, very individualized in this situation, okay? Protecting the remaining kidney requires both medical vigilance and self-care, controlling blood pressure, sugar, and weight, avoid nephrotoxic agents, maintain checkups, empower patients toward the education, through education and shared decision making. And questions. Am I on time? Okay. Okay. Any questions? Yeah.
When you talk about home blood pressure monitoring, how often, any specific times of the day?
This is what I do, and I teach my patients this, okay? And I'll put it here. If you go to the National Kidney Foundation website, they have some very good instructions. Interestingly, even if you don't, they say, go to the bathroom, have an empty bladder when you check your blood pressure. What I tell people is sit on a table where the machine is sitting at the level of your heart. So if you have to keep a couple of books there or whatever it is, keep it at the level of your heart. Put the cuff on your arm. And I usually tell them, sit for 5 minutes, and the only thing you're allowed to do is listen to music. And I also, big rule, get the spouse out of your room. Anybody, in fact. Everybody should be out of the room. You should be alone. Because the sprint study was the big study we had, and everybody was out of the room, including the nurses and the doctors. You don't want the doctor or the nurse in the room when they do this. Once you put the cuff and sit quietly for 5 minutes, then I tell them to, and I do it before they take their medication. Because if you do it after, then it'll be better and you'll feel great. Before you take your medications, I would say twice a day, morning and afternoon. And I usually tell them, take the blood pressure 3 times with 1 minute, and now a new study came and said 30 seconds is enough. Break between the numbers. And I usually say the first number is usually high because of anxiety. Second and third usually go together. There are machines which are available which will take 3 numbers and you don't see those numbers and then send it to your smartphone. But that's the way to do blood pressure. But again, hand shouldn't be hanging. You shouldn't be sitting in a couch. You should be sitting in a chair with both your feet on the ground on a straight back with sitting on the dining table. That's like a standardization. Okay, if you do it that way, and all my patients get that instruction every time to do it that way. Yeah.
I use a wrist, no? I was hoping I misunderstood you.
Up here, no finger, no wrist, nothing, and no Apple Watch blood pressures, okay? They're coming out with fancy made in China watches which tell you they can give you a blood pressure from the arm. There is some interesting technology out there. There's a strip called Zoll, which you put on your chest, and it measures your continuous ambulatory blood pressure. But it is not prime time yet. Okay, Zoll actually has been FDA approved. I tried it on myself, and it's not bad. They use some kind of cellular technology to send it out, and you get it. But right now, as it is, we all believe in the cuff and the arm. Please above the elbow, not even the wrist or the finger. Okay? I think there's one there.
Sure.
Yeah, when you're getting, infusions, or even if you're not getting infusions, but you're taking like TKIs and different pills and things, and you only have one kidney, is it beneficial to get a hydration, at least, and that's the other thing I'm wondering, how often is it beneficial, and then how often? Like once a month, or
Hydration before the medication, you're saying? Or you're saying, I mean, you want to be well hydrated. You don't want to be
taking
dehydrated.
this stuff every day, regardless, but I'm just saying like.
Okay, so if you're taking a pill every day, my understanding, the question is, if you're taking a pill every day, should I go once a month to the infusion center and get a dose of IV? Is that what you're asking? Something like
You're
that?
taking like multiple, like I take a TKI and I take that TCM or whatever it is. So I'm taking 2 pills now and I'm not getting infusion. So they make me really sluggish and tired. So I was getting like hydrated for diarrhea and all that other good stuff. But now that you're talking about the kidney, would that also benefit if you only have one kidney?
Well, the kidney is happier if you are well hydrated, okay? But the question is, can you get away the hydration orally, or is your diarrhea severe enough that you need IV hydration? That's only your doctor can evaluate you and tell you and see how it is. Because getting hydration once a month or once every 2 weeks IV for something who's taking a pill every day and having diarrhea and getting dehydrated every day may not be enough. You may need to take some medicine to slow down your diarrhea so you don't get diarrhea, because unless you're constantly getting IV. So it depends on how much kidney function you have, how easily you get dehydrated. And if you get dehydrated, your kidney function is going to get.
Yeah, the diarrhea is under control now. I'm just worried about, I've never seen a nephrologist. I should have, because I've been doing this 15 years. But I've never seen one. But now I'm worried about little Lefty, and I want to, keep it healthy. So.
Well, talk to your primary doctor first and see if your numbers suggest that you need to see a nephrologist. But like I said, if those tests have ever been done, the cystatin C and the urine albumin creatinine ratio are abnormal, there are things we can do to protect your kidney. But again, if he looks at you and says you are dehydrated, we got to figure out why. Maybe you're on a water pill, which is making you dehydrated. I don't know. There is a blood pressure medicine called hydrochlorothiazide, which we use a lot. And if you're taking that, you may be dehydrated simply from that too. So it's important to know what. But hydration is important. Just like he was mentioning, before you get a contrast, we usually give a whole bunch of fluids to hydrate you and then give the contrast. The risks of kidney damage from the contrast is much alleviated with that.
Yeah, and they've never done that. All they ever do is hang the little bitty bag, but I've asked about it through the past, and I got a deal for like almost 4 years. And I kept asking, but they never put hydration in there, like an actual IV bag.
Okay. Well, just discuss it and see what they think. Maybe don't
I
need it.
just wanted your opinion.
Okay, thank you. Yeah.
Thank you. Quick question. So if you've got one kidney, normal function, EGFR, creatinine, and all that good stuff, what if that kidney develops, this remaining kidney, stone and or cyst or both? What would a strategy be?
A cyst, people develop after the age of 35, 40, it's not uncommon to have a cyst in your kidney, as long as they call it a simple cyst. Once that cyst becomes complex, then a urologist has to follow it closely to make sure it is not getting cancer. But if you have kidney stone, obviously the stone, even if you have 2 kidneys, you can get stone, but K may or may not block. But if you have a stone kidney, you have to evaluate why you get stones and look at the hormone analysis, analyze the stone, and there are ways to protect you from getting more stones.
What do you recommend for an ideal protein? Like how many grams of protein would be?
Well, I'd mentioned out there.
You
if
said
you
high
have,
protein. I wasn't sure what, like, is there a limit?
Yeah. I mean, I think for normal diet, average diet, to maintain a healthy lifestyle, 0.8 grams per kilogram is plenty. If you go to 1, you're pushing it. But I know these weight builders and all they're talking about 1 gram per pound, which is like 2 grams per kg, which is ridiculously high, especially in people who have kidney disease and stuff like that. Those are the youngsters and TikTok. My medical students will come and tell me, can I do that? No. I mean, if they want to do it, they better check the urine albumin creatinine regularly. But for somebody like average person who's just wanting to maintain a healthy life, 0.8 grams is probably plenty, maybe pushing it to 1, but I don't think you need to do more than that. Okay, thank you.